Can you see my screen and am I audible?
Yes, sir, we can see your screen and you are loud and clear. Good to go.
First of all, I'll thank Korean Society and All India Ophthalmic Society for giving me this opportunity on an international platform to speak about surgical options in macular hole. Macular hole is a defect of the foveal retina involving its full thickness from the internal limiting membrane to the outer segment of the photoreceptors. The cause is usually traumatic. Is traumatic. Usually, it is idiopathic in 90% of cases, and many of the myopes will also have myopic macular holes. Uh, if we go for staging of macular hole, then it is classified into four stage. And stage 1A is foveal detachment with macular cysts. Stage 1B is donut-shaped yellow ring. Stage 2 is full thickness macular hole, less than 500 microns. And stage 3 is greater than 500 microns. A full thickness macular hole associated with total PVD is stage 4 macular hole. OCT is the diagnostic tool and also helps in staging of the macular hole. Prognosis of the macular hole uh, uh, also depends on various indices like hole formation factor, macular hole indices, DHI, THI, and FHA. We are not going to discuss all this in detail because this is outside the preview of this talk. Uh, if we see this is a stage 3 macular hole, the size is less than 400 micron and the vitreous is attached to the flap of the macular hole. This is stage 4 macular hole. You can see that there is a total posterior vitreous detachment. Uh, Whenever you do surgery, you usually aim for a type 1 closure. Type 1 closure means there is an return of the foveal contour and all the three layers in the OCT are joined together, the photoreceptor, the internal limiting membrane, and the outer layer are joined. And this we call as in type 1 closure. In type 2 closure, the edema goes, but the hole still remains and it's not closed. This is one of the patient with very large macular hole of 2000 microns, and we did a vitrectomy with ILM peel, and you can see almost there is a closure of the macular hole. Coming to the treatment option, the medical option, very small holes can close spontaneously. Uh, Intravitreal oculoplasmin was recommended initially, but not many people are using in our country because of the high cost and the success rate are less to somewhere around 32 to 35%. So most of us in India are using surgical option, that is vitrectomy with ILM peeling. So I'll be discussing the techniques of doing macular hole. So this is my first video. There is an macular hole here. You can see there are tricot staining is done. And once the PVD is induced, BBG dye is introduced. You can see this ILM is stained with BBG, but there is also a negative staining. So once you have a negative staining here, we realize that there is a big epiretinal membrane. And because of this big epiretinal membrane, you are not getting a blue stain here in this area. A diamond dusted scraper is used to create an edge, and this epiretinal membrane is removed in toto. And once the epiretinal membrane is removed, we create an edge inferiorly. And then we go ahead and restain this macular hole with BBG dye. And if you see, the area which was not stained previously is now stained with BBG dye. And then ILM peel is initiated. A macular rhexis is done. Always go tangentially, don't go antero-posteriorly. A good flap is made, and I prefer to do a large ILM peel even if the macular hole is small, because doing a large macular peel leaves all the traction within the arcades and I prefer to do an large arcade to arcade ILM peeling. Once the large ILM peel is done, fluid air exchange is done. Post-operatively, this patient did well. This is my second patient. You can see that there is a large macular hole somewhere around 700 microns. PVD is induced with the help of the cutter after tricot staining. The procedure should be gentle and you should use an high suction. You can use either cutter or you can use a soft tip needle. The vice ring comes and then a total vitrectomy is done. The ILM is stained with a BBG dye, and in this case, I'll use a catalyst ILM forceps which has a bigger lip. And in this forceps, you can see the edge catching hold of the ILM. The edge is my preferred technique is scrape and then do a peeling. And so I create an edge with the help of an diamond dusted membrane scratcher or with a finish loop. Once the edge is created, I'll do an flower petal like peeling because this is a large hole and I prefer an inverted flap technique in a large macular hole. The ILM is caught and I'll not cross the macular area, the fovea or the macular hole, and multiple petals of ILM is created. The advantage of this technique is that I don't have to stuff the ILM into the macular hole. Once I do a fluid air exchange, automatically all the petals will fall over the macular hole and there will be no communication between the vitreous cavity and the macular hole, thereby increasing the rate of success in these patients. Once the flap is created, I enlarge the ILM, my macular excess, and as I told, I prefer to do an arcade to arcade ILM peeling. The reason behind it, it increases my success rate, and the flap is trimmed. You should be very careful while trimming the flap. The suction should be 50 millimeters of mercury. If you increase, then you can pole of the flap will come into the cutter and you'll lose this island flap. You can see this cabbage-like appearance on the posterior pole, and the blood is then cleared and fluid air exchange is done. And this is my last case where this is a case of a failed. I did a macular hole surgery, and this patient failed. And you can see the size of the failed macular hole is somewhere around 1800 microns. So was a difficult case for me. I took the patient for surgery, and I plan to do an ILM flap within macular detachment. You can see I have done an staining here, and you can see there is an arcade to arcade peel. So I initiate the ILM graft beyond the arcades, and I bring it to the nasal side. I can harvest a good ILM flap. It is important here that you don't pick this flap with the help of an ILM forceps, because it will be very difficult to again place the flap over the macular hole. So a PFCL bubble is placed, and then with the help of a membrane scratcher, this flap is dragged over the macular hole. It is gently brought into the center, and you can see putting this flap into the macular hole. If you see, I thought this flap is very small, so I tried to harvest another flap from intranasal area, and the flap is not very good. So I thought I'll use an it gets stuck into the membrane scratcher. I use a bimanual technique, and I thought I'll hold with an alum forceps this flap and place it over the macular hole. You can see it's very difficult to place it over the macular hole because it doesn't goes inside the PFCL bubble, and also you cannot dislodge with the help of the membrane scratcher or another instrument. So I lose this flap. Then I thought this flap is more than enough. It's what I do. I do a manual here. Since it's a constellation, I don't want the flow of the machine to dislodge this macular flap. So what I do, with one hand, I remove the PFCL. With this cannula, what I do, I inject the BBG stained viscoelastic. Once the viscoelastic, if you see this viscoelastic is injected, the flap doesn't move from the macular hole, the PFCL is removed. And since the size of the macular hole is pretty large and I don't want to land up into another failure, so I create macular detachment of the posterior pole to make the retina elastic. Once you can see the fluid traveling from the subretinal space from the macular hole, the fluid air exchange is done. And this is 1 week post-operative. You can see the macular hole is closed and this patient had 624 vision. So coming to prognosis, hole closure rate varies from 91 to 97%, depending on the size of the hole. Prone position is reduced to 3 to 4 days. And usually I customize my patient with OCT. I do a OCT once the uh, air or the gas bubble goes above the macular level, and once the hole is closed, I tell my patient don't lie in hole position. Visual acuity of 20/50 or better was achieved in 60% of cases with the duration of less than 6 months, and in 31% of cases with duration of 6 months or longer. So to summarize, advancement in instrumentation has made macular hole surgery the most sought after surgery. Prone position is required only for 3 to 4 days. Result of macular hole surgery is between 90 to 97%. Visual gains are 3 to 4 lines. Thank you for your kind attention.